Yes, I'm here. Good afternoon and good morning and good evening, depending on where you're at. Okay, so we're going to go ahead and get started. Again, my name's Mike Deck, and as I said, good morning, good afternoon, good evening, where you're at. It's amazing technology, isn't it, that we can all sit in front of our computers and either use our speakers or our telephones and virtually attend these type of webinars. I want to thank PPS Plus for the invitation to go ahead and speak to you guys today and kind of give you an overview of where we're at in electronic health records when we're looking at the home care and hospice industry. And again, I want to thank PPS Plus for the opportunity to give you this information as well. So, kind of what we're going to be going through today on our agenda is we'll be covering the overview of the current federal regulations and mandates regarding the use of electronic medical records. There's a lot of misconception. With hopefully we've cleared up in the air, but about 2 years ago, if you were in the industry, you probably heard that it's been mandated by the government to go electronic. I have to go paperless, and we're going to explore and take an in-depth look at that actual law to see how it does and does not apply to home health and hospice. And then take a look at the forecast of the use of EMR in the ACO and the IPA world. And ACO, obviously, Accountable Care Organizations, IPA, Independent Physician Associations, and also CBOs, community-based organizations. And kind of looking at the care environment of tomorrow. So we know that our traditional, let's say our traditional Medicare home health environment that we've enjoyed for the last 13 plus years there's a lot of forecasts, changes being forecasted on that. And how does electronic medical records play a part into that? And then finally, questions and answers for you as well. So a little bit about myself. I have been in home health care management for a little over 15 years. I currently sit on the board of advisors, advisory board for a couple of agencies. I live in Detroit, Michigan. I joke around. I took a hiatus for a little bit, and I actually built a assisted living facility because I thought that would be a good market to get into. I did that right before the recession hit and tried to finish construction during the recession. So I joke around, for those that know me, I did not have gray hair until I decided to build an assisted living facility. I also have a unique kind of a little bit of a background or a perspective that my wife is a physician. And I always joke around when people hear me say that in the Detroit area. They're like, oh, can we get a referral? Well, she's an OBGYN. She's a baby catcher. But I have been a consultant to her group. She has a private practice that now has approximately about 10 physicians in it. And they've got 4 offices around the Detroit metro area. But a consultant with them on getting them up to an electronic medical record system and getting on of it. I'm a nationwide speaker. I will be presenting at NAC. Some of this information will be actually presenting at NAC. I'm on the speaking circuit, and I joke around. Probably my biggest claim to fame is that I am a husband of 1 and a father of 2, and in that order as well. Currently, I am a project manager for Healthcare Synergy, and Healthcare Synergy is a partner of PPS Plus. And this webinar is really not going to talk about the Healthcare Synergy application, other than maybe a little mention here and there, because it's not what we're here to talk about. And we're here to talk about electronic health records on it as well. But I do want to throw that out, that I am a project manager for the Healthcare Synergy, and that's going to add a lot of validity to one of the points I'm going to bring up here, because I'm going to start sharing with you some examples of a pilot program that we're currently doing in the state of Michigan as well. So again, if you have any questions, go ahead and just type them into that question. I promise that we'll be able to get to them at the end as well. So let's go ahead and dive in. It's always fun to read legislation, right? And I joke around. When you try to read the Federal Register, if you're like me, I remember when HIPAA came out, and the HIPAA reform, or not the HIPAA reform, but the changes in HIPAA about 2 years ago. And they actually came out, and I was flying out to Las Vegas to give a presentation. And I was like, you know what? I'll read the HIPAA rules from the Federal Register directly on that flight out. Well, I got through 2 glasses of wine in about 3 pages before I said, forget this. I'm just going to go ahead and relax. So it's always fun to read regulations and the Federal Register. So we're going to take a step back in time. And in that is we want to look at the stimulus package that was created during the first administration of the Obama administration, right? And in the stimulus package, there was an item called the Health Information Technology for for Economic and Clinical Health Act, or simply known as the HITECH Act. And this pretty much put in a law for the use of electronic medical records. And let's take a step back. It's, President Obama, this was done during his administration, but President Bush Sr. was the very first one to kind of see the use of electronic medical records. And also, while we're talking about that, I'm going to be using 2 terms a lot today: electronic medical records and electronic health records. And there is a big difference between the 2 of them. Electronic medical records, if your agency is using software where you're collecting and storing the patient data electronically, that is an EMR software. That's electronic medical records. And that's quite different than electronic health records. And what electronic health records is where we take the EMR of multiple providers, say a home care, a physician, a DME, a hospital, a urgent care, and collectively put all that data together. That forms an electronic health record of a patient. So there's a big difference between EMR and EHR. And what this act did is at the beginning, in order to get that EHR stage, we have to have EMR. And so that was kind of the wish of the legislations prior to, and it started to come to fruition into the HITECH Act. And in the definition, when you first read it, obviously if you read any law, you got the definition and then you got the nitty-gritty, right? So it looks pretty good because the definition says the term healthcare provider includes a hospital, a skilled nursing facility, home health entity, or other long-term care facility, healthcare clinic, community mental health center, as defined in Section 193B-1. So when we first start reading this law from 2009, it's like, oh, wait a second, we better pay attention, because home health entity or long-term care facility or a hospice facility or skilled nursing or assisted living, we're included in what a definition of what a healthcare provider is in this law. So the law pretty much states that there would be an incentive payment for adopting and meaningful use of certified EHR technology. So what this means is that if you're using an EMR system and you're billing Medicare and Medicaid programs, because most Medicaid programs follow this as well, then you would get an incentive payment if you used and met the following conditions. Right? So it means that, hey, if and we'll talk about the 3 conditions, but basically it means that I'm going to get an incentive payment on it. That incentive payment was on a sliding scale. So we heard a lot that, oh, this is the last year to sign up for the EMR. This is our last year to get mandated, or we're going to get fined. And what that means is for physicians is this is their last year to start getting their incentive payments. And it was an incentive payment, again, it was designed on a sliding scale. And I know it probably perked your ears up because you're like, oh, wow, incentive payment. Because I know, across the country that in our industry we're always struggling, right? And even looking at the 2015 proposed rule changes, we always forget that, remember that 2% sequester? That's still in there, right? And we're always getting our payments lowered. I sometimes feel that home care and hospice are treated like the stepchildren of the healthcare industry when we provide the most viable option, the most cost-effective option. But I'm not going to get off, I'll stop getting off that tangent. But basically what the law did, since it was part of the stimulus package, was it made funds available for the use of electronic medical records. Now in our industry, in order to qualify for that, I shouldn't say in our industry, but in order to qualify that, there were 3 conditions that you had to meet. And the groups still have to meet them today. Number 1, you have to be defined as an eligible professional. And then you have to use certified software and demonstrate meaningful use. You do those three things, and you can receive some incentive payments on the Medicare and Medicaid from Medicare and Medicaid programs. However, there are three requirements, right? The eligible professional, the certified software, and demonstrate meaningful use. Unfortunately for us in the home care and hospice and post-acute care world, those three requirements become our three obstacles and the three main reasons why this law does not apply to us. So let's go in and look at those three requirements again. Number one is that we have to be an eligible professional. And an eligible professional means a physician, a dentist, a nurse midwife, a nurse practitioner, or a physician assistant, as long as they're practicing in a rural health clinic. So the eligible professional, while home care and hospice and a post-acute care provider was listed in the definition of healthcare provider, we are not listed as an eligible professional. So we get baseball season, right? We got strike one against us. We're not eligible for this. So unfortunately, if you're thinking that maybe I can get a little extra money because I want electronic, we're not going to be getting that from the government. So step number one, obstacle number one for us, strike number one. Strike number two is that we had to use certified software, right? And there's a lot of home care and hospice software vendors out there. And what the term certified technology means is a qualified electronic health record is defined in the blah, 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 that is certified pursuant to the blah, 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 blah. That is what a certified EHR technology. So what happened with this law was there was the creation of what's called the ONC, the Office of the National Coordinator. And their funding originated from the HITECH Act. And what they do is they create the requirements for that certification process. They don't actually certify it, but they create the requirements that the software has to do. The ONC has now expanded their reach, and they are really becoming the federal branch to see, now that we've already, we're already 5 years past this law, right? To see where we can take it next and how we can use it. And I'll talk a little bit further about the ONC. But obstacle number two for us against this law, against this law about getting the incentive funds, is the fact that we did not have any certification criteria for home health and hospice. Now, the ONC created that certification criteria, but they're not the ones that actually certify the software. So as a software vendor, we would contract with one of 5 companies, and they're located throughout the U.S., and they're known as ONC authorized testing and certification bodies. Now, this list changed. This used to be 6. And there was another certification body called the CCHIT, Certification Commission for Health Information Technology. And if you had attended NAC, you would have seen that they were there as well. They're even up until last year. And there are a number of home health vendors that had their software certified through the CCHIT. And what CCHIT did is they said, okay, you know what, since this law doesn't apply to home care and hospice, but it is a very viable industry right now, we're going to create our own certification criteria that home care and hospice vendors can use, and they can get certified by us as kind of a stamp of approval. And there are a few software vendors out there that went and did get certified by the CCHIT. Well, that happened in October and then of last year. And then what happened in January was the CCHIT actually no longer became an ONC authorized testing body. And they are now just a company that does consulting on helping software vendors get through all the paperwork to become certified. So you may hear again, the vendors that went and got the certification, and it was a voluntary status that they could do to prove that, hey, listen, this home care piece of software would meet some of the requirements, but it doesn't meet the strike two that we don't have the certification criteria. Right? I know it's a lot of stuff here, but just remember those three steps. We had three obstacles. So the certification, unfortunately, in our industry, in home care and hospice, we don't have the certification criteria that us as software vendors can go ahead and create the software to apply to this mandate. And bottom line, what this all means, and even before we get to strike number 3, which is we're going to talk about meaningful use here in a second, is that the funding for this is actually going to be ending here next year. So even if we change this law and we became an eligible professional and we got the certification criteria, the funds that were allotted have now been used in this as well. So strike number 3 was that we had to demonstrate what's called meaningful use. And this is a strike for us against receiving the financial incentives. But this is going to, you'll see here in a little bit, why this is going to become a very positive for us. And what CMS did is they recently released the final rule for stage 2. They're actually still working on releasing stage 3. So we had stage 1, stage 2. They have yet, from my understanding, they have yet to release stage 3. But in stage 2, their intent was to increase health information exchange between providers and promote patient engagement by giving patients secure access to their health information. So what the meaningful use, obviously on the home care and hospice side, that becomes strike number 3 for us, because we can't demonstrate, in an agency you can't demonstrate meaningful use of the software because we didn't have any certification criteria to develop the software for you to demonstrate the meaningful use, right? But now in today's environment, physicians and hospitals and the referral sources that you're working with, if they're receiving the EMR incentive funds, they are required to demonstrate that they share information about a patient electronically with other providers. And we're going to talk to you about how they do that here in a second. So why this, I wanted to focus in a little bit on this, why this becomes important, does not become important for us as far as our strike. We're not going to get the funds. It becomes very important for our referral sources, because that's something that they have to do, and they have to show that they're exchanging data across multiple providers. So then we're going to scoot ahead a little bit. And we had the Healthcare Reform Act of 2010, right? And the big thing that came out of the Healthcare Reform Act is, the idea of creating these ACO organizations. And if you're unfamiliar, if you've never heard what an ACO is, it's basically what's called an accountable care organization. And ACO participants may share financial gains generated from improved clinical and economic performance, provided that required goals and patient safeguards are met. Basically, what an ACO is it is, in a simplistic terms, the simplest that you could probably understand, is it's a private HMO, right? I joke around, it's like an all-boys club. And if you're not in the all-boys club, then probably are not going to be able to get patients away from the all-boys club. And what it is a group of, normally it's generated with a hospital. They've got a group of physicians and care team providers that will collectively work together to take care of a patient after in a post-acute care stage environment, with the main goal of being able to reimburse, not reimburse, but to save money on the care while keeping that patient out of the hospital, keeping them from being readmitted. So a perfect example on the ACOs is, let's say that I fall down and I break my hip, right? I'm 67 years old. I've got my Medicare. In today's modern Medicare world, non-ACO, I'd fall down, break my hip, have a hip replacement surgery, and I would go, most likely after the hospital, I'd be discharged to what? A rehab facility, a skilled nursing facility. I'm not quite safe enough to go to my home. And how long would I stay at that skilled nursing facility? Probably for 100 plus, right around 100 days, right? 99 days. Because what happens on the day plus 1 of that episode? I have to, as a person, I have to start paying for the skilled nursing, right? So it's amazing how many people get better when it comes to the time for that copay to kick in. And so let's say I'm still not walking correctly. Where am I going to go? I'm going to go to home health, right? And how long are you going to keep me on home health? Well, one episode with probably 13 or 19 therapy visits. And I'm still struggling. So you're going to keep me on a second episode and bring me on, and finally I'm able to walk around again, right? So in that modern world, Medicare paid for the patient for 3 episodes. 1 episode for the skilled nursing, 2 episodes of home care. Well, does it really take that long for me to, build up the endurance to start walking again? Wouldn't it have been better to have the physical therapy come to me and maybe have some home health aid services and some other, maybe a little bit of non-skilled, or only spend a week in that? That's what the whole goal of an accountable care organization is, to stop that type of spending on it. And on the bottom line, that sounds really good. But on the bottom line, what it means is that home health care and even hospice now, we like to think of ourselves as a separate entity, right? And we work with our physicians, we work with our referral doctors, but, realistically, I joke around, I'm married to one of them. I know how bloody hard it is to get them to sign a 485 or a change order, whether it's even on paper or electronic. That's how today is. And what the ACO type of environment is no, we're going to be working very closely as a full care team. Meaning that the home care and the hospice is not just going to be an individual entity, that you're going to have people like a case manager from the ACO take a look at that. Now, that's the ACO world. What we're also starting to see now is a lot of private insurances are coming with the same value-based care programs nationwide, right? So if you're working with some of your private insurances, you'll probably start seeing that, hey, you know what? Now we're going to be getting, basically a bundled payment to take care of this patient. No matter which way we take care of them, we're going to get that money, and we have to keep the patient out of the hospital, because if the patient goes back in the hospital, we don't get the money, right? And it's a bundled payment initiative. So that all started under 2010. Now, we're not going to really talk about the pioneer ACOs on it, because that's a little bit, we've already talked about it. But now I want to marry the two together. So in 2009, we had the HITECH Act. 2010, we had the Healthcare Reform Act. 2 years ago, the ONC, the Office of the National Coordinator, said, hey, wait a second, you know what? We're going to look into our crystal ball, and we're going to see how these changes need to work together. And so this is coming directly from the ONC's Health Information Technology year, I won't say year in review, but year goals from last year. And these are direct quotes from their document. It says, second, ongoing payment reforms initiated by the Affordable Care Act, including accountable care organization, medical home models, and bundled payments, are an even more important potential driver of providing motivation to exchange information. Electronic health information can be a critical element in the implementation of business models, such as bundled payments and accountable care organizations being implemented through the Affordable Care Act. These delivery system reform models will rely on richer and more timely information to better align payments with the actual costs of providing efficient care. Again, this is from a memo that was issued by the ONC. That last line is so powerful, no matter if we're doing documentation electronically now or even on paper. And because it's going to have a lot of consequences for us. And it says, these delivery system reform models will rely on richer and more timely information to better align payments. More timely information. I've been in home care for a while. How often, realistically, do we see that our clinicians will give us a completed document the day of the visit, or even moments after the visit or during the visit? It's kind of that pie in the sky. I would love to have that. But realistically, I'm going to go back, let's say 10 years ago. And if you guys all think about where your agencies were 10 years ago, let's say payroll was due on Friday, right? All your clinical documentation was due on Wednesday. Where were all the clinicians Tuesday afternoon? They were all in the boardroom, or they were in a conference room, or at their cubicle, or at their home, filling out all their documentation. Why? Because they had to get it done, because if they didn't get it done, they weren't going to get paid, right? And that's unfortunately some of the mentality that our caregivers have. Well, now, as we're looking at the healthcare of tomorrow, we've got to work on help changing that mentality. And obviously doing it electronically is a big benefit, but there's also a cost to go into EMR. You can still get the benefit of what I'm going to be talking about here, even by using paper. Right? Obviously, it's easier to do it electronically. What we have to do is work with the clinicians to get into the mindset that that documentation is not just a vital piece of information for you to get your paycheck. That documentation now becomes a vital piece of the patient's electronic health record. And notice I emphasize electronic health record instead of EMR. Because when you're involved in these type of organizations and when you're involved in working as a care team, it's not only going to be your agency that's going to be wanting to look at this documentation. It's going to be a case manager that's in charge of the ACO. It may be the physician. It may be the fact that, hey, listen, you know what? This patient's coming in off of, let's say, skilled nursing facility, right? How crucial or how beneficial would it be for you as a home care agency to take a look at that skilled nursing facility's clinical documentation prior to going out and doing your initial assessment or reassessment of that patient, right? Being able to find out, having the other providers help you work as a team as opposed to this concept of, hey, we're a single healthcare entity. So how do you manage your clinical documentation now? Some things to think about. ACO is based on the principle of monitoring patients' care to keep them from the hospital. Documentation can no longer be done at the clinician's expected time frame, but within minutes or less than hours from completing the visit. So these are all pluses for moving into electronic medical records for your agency, right? If you haven't done that before. And if you have, good for you. Now, I didn't have a slide, but let's talk about that transition from paper to EMR. A lot of agencies will say, okay, good, I want to go electronic. If you're in that process, or you have done that process, or you've been electronic for a while, I've got another challenge for you. And especially if you got a survey coming up. That is to take a look at your existing policies and procedures that you have in place for your particular agency. And make sure that if you wrote them and you haven't reviewed them in a while, obviously we should be reviewing them every year, but you know how it goes, right? Oh yeah, they're good. We got our JACO survey a couple years ago, that we were fine. Now that we're using electronic medical records, do those same policies and procedures apply? For example, perfect example, a lot of agencies stated that in their original policies and procedures on the initial assessment, a copy of the patient's medication will be left at the patient's house after the initial visit, right? So if you think when you're on paper, we did the triplicate form for the medications, wrote them down, ripped off the sheet, left it at the patient's house in their folder, and came home. Well, now we moved to an electronic system. So the policy says that a copy is left at the patient's house, but we're entering them on the computer. So we got two options. We got the option of that we could have the clinician bring a printer to the patient's house, which you may laugh about a little bit, but I actually know of one agency in Southern Florida that the nurse did just that. She put a printer in her car and would print things out and go out to the car, get them, and bring them back in. Or we change that policy and procedure to a copy of the medications is either dropped off or mailed to the patient on a subsequent visit or viewable online. All those are acceptable. But what we got to do is take a close look at your individual agency's policies and procedures. And if you are electronic now, or you're about the way that you're going to an EMR system, that you make sure you're not breaking your own laws. And you want to do that, prior to the surveyor coming in and taking a look at it. Okay, and speaking of surveyor, I'm going to also, I didn't have the slide, but something I do want to let everybody know. January 1st of this year, when we're talking about EMRs, January 1st of this year, the OIG, so I always call the OIG the CMS police, right? They're the watchdogs that watch over CMS. Well, the Office of the Inspector General sent a memo to CMS, and it instructed CMS to instruct their surveyors, as well as any contractual surveyors, the RACs, the ZPICs, and the MACs, that if you go to survey a healthcare provider, so whether it's a home care, it's a hospital, it's a hospice, outpatient therapy, if they're using electronic medical record systems, you need to pay very close attention to what type of EMR software they are using. Certain software out there will allow what's called cloning of visit notes, where, hey, I have a visit note and nothing really changed, so I can click a button and it autofills my visit note for the next day, right? Or I have a system that allows me to have a check mark, and I just say, I check 4 things off in this check mark, and it automatically creates 4 pages of documentation for me. That is not a really truthful system. I understand the benefits that it has for the clinicians because it's easier for them to do their paperwork, right? Because things don't really change. However, CMS has been instructed to start looking very closely at your EMR systems to make sure that you're not doing that. Because if you are, that's going to become another stipulation, another reason why they can start saying, nope, you know what? All these documents are identical to the visit documents from before. These claims are going to be denied, and we're going to, if it's a rack, we're going to adjust it. So that's one thing that, again, it was kind of kept quiet. But the OIG did release this memo. And I have a copy of the memo. There's a couple other things too that I didn't include in the presentation. If you want a copy of any of the stuff that I'm talking about, feel free to go ahead and just let us know, and we'll be able to get that for you on there as well. So taking a look at the closer ACO. So now we're in the environment that we have to work as a care team, right? We're no longer the no longer the single entity. So how are we going to do that? We're going to do that through what's called a health information exchange. And I joke around, we all heard of health insurance exchanges, right? Up until last year. It was funny. I said HIE to people and they said, oh yeah, the health insurance exchanges. I was like, no. There's another important term in our industry a lot of people don't know or recognize, and that is Health Information Exchange, or HIE. And it actually encompasses two related concepts. It's a verb and a noun. And the verb is the electronic sharing of health-related information among organizations. It's how we get to an EHR system, right? Remember, we got to the EHR system because we combined a whole bunch of EMRs. So an EMR from a home care, EMR from a hospice, from a physician, right? So the actual sharing of data among those systems is a verb, and that's a health information exchange. It's also a noun, and it's an organization that provides the services to allow this to happen. Now, this may seem like a lot of pie in the sky stuff, and let's talk realistic, very simple terms, right? I'm working with a physician, and I get my referrals, and I've got my patient. We always kind of think of simplistic terms that way. Well, that physician may have, let's say, Epic as their EMR. And I've got Healthcare Synergy is my EMR for my home care agency. Well, Healthcare Synergy is not going to talk to Epic, and Epic's not going to share information with Healthcare Synergy. We're competitors. Now, we get into a more complicated case where we're adding more care teams, right? Maybe we got a skilled nursing facility that has point-click care, and we've got an urgent care that's running McKesson. Well, all of these systems, we're not going to be able just to go up as Healthcare Synergy. We're not going to say, hey guys, here's my database. Read as much information about the patient as you want. And if you start thinking about it, let's say that we've got four entities, okay? We've got a home care, we've got a physician, and we've got a urgent care, and we have a skilled nursing facility. So look at your hand and hold up 4 fingers. And what you want to do is, okay, so the exchange of data, well, how are we going to do this where we have basically 4 lines that are going to go across all of our fingers, right? And we've got to make sure that the line that goes from the home care agency goes to the physician, and then we've got a line from the home care agency to the urgent care, and then the home care agency to the skilled nursing facility. So that way the home care agency can talk to all 3 providers. Yeah, it's pretty simple. Except we go down to the physician. The physician has to have a line not only to the home care agency, but then to the skilled nursing facility and also the urgent care. And you can see it becomes almost like a spaghetti mess, right? So as part of the HITECH Act in 2009, there were funds allocated so each state has what's called a health information. They have the noun, a health information exchange. And these are organizations, and again, with any entrepreneur or capitalist that we have, the original organizations were funded by the government, and then private individuals and equity firms created their own. But these are the organizations that facilitate the sharing of information. So, for example, here in the state of Michigan, we have basically, we had 2 organizations. One was called Great Lakes Health Information Exchange. The other one was called Michigan Health Connect. And these were 2 companies, organizations, I won't say companies, but organizations that were started up to facilitate the sharing of data. And by facilitating, what it allows us as software vendors to do is that we can build an interface to exchange this data. So much like all of the software vendors have built an interface to submit OASIS data up to the government, right? We can all come together and agree on standards and share information back and forth, no matter what type of system you have, through what's called HL7 messaging. We can share that information no matter what software we're using. And that's what these health information exchanges do. So they actually are the ones that, as a software vendor or as a practice or a home care agency, you would sign an agreement with them, and you would be able to exchange the data either directly from your EMR software, if they have an interface built, or you'd be able to go online and review and enter some of the information there as well. Sounds like a lot of pie in the sky stuff, right? But it's very realistic. And how does this help us? And what we have done is I've spearheaded a pilot program here in the state of Michigan to prove the usefulness of this. And we started off very small. And what we did is we worked with Great Lakes Health Information Exchange, and actually they have now merged. So they're now Great Lakes Health Connection, I believe is what they're called. But what we do is we started off something that's very, very simple, but yet very, very powerful. And that is that we're working with ADT messaging. And ADT stands for admission, discharge, and transfer. So what this means is if the hospital and all the providers are on the same HIE, when the patient gets admitted to the hospital, if the hospital system has, 9 times out of 10, their hospital system already has an interface with the HIE. As soon as that hospital hits the enter key, a message is sent to the HIE, the patient has just been admitted to the hospital. And, people always say, was it real time? Well, you know what? It's close enough to real time because it comes right in. And what the HIE does then is any other prescriber that's subscribed to this patient will now, either through a virtual health record that they can log on and see those admissions, or if they're using an EMR software that has an interface, it will automatically alert them that the patient's been admitted. Why is that important? Just think about that for a second. Just that simple thing about being able to understand when your patient and know when your patient's being admitted. I joke around, realistically in home care, right? Let's say we're visiting the patient once a week for skilled nursing on Wednesdays. Patient goes to the hospital on Saturday. When do we normally find out about it? We find out about it on Tuesday evening when our caregiver is calling that patient. Or on Wednesday when our caregiver is knocking on the door. Where's the patient? Where are you, Betty? And, Betty's neighbor, she went into the hospital on Thursday. We don't know about that. So, one of the biggest benefits that we can use health information exchanges for is a very simple thing, understanding where our patient is. And so we have what's called ADT. So if you hear ADT, that's what that means. It's the admission, discharge, and transfer. So hey, one of my patients from home care has been admitted to the hospital. I received an ADT message, or I saw it on the virtual health record. And then the patient was just discharged, or wasn't discharged, but they were transferred over to a skilled nursing facility. I'm getting that message. I know where that patient is. The patient's being discharged from the skilled nursing facility. Whoop, I'm ready to hopefully come back in and get that patient on. The other information that we see vital and happening inside the home care and hospice world is the transcriptions. And so what we're looking at, and what we're doing here as part of our pilot program, is that when we send an admission to the HIE, we are also sending some of the 485 orders and goals in there. So continual care documentation, right? So we know what's going on. And the other care team coordinators and providers, and especially as we're looking forward, forward thinking, progressive thinking about these accountable care organizations. Let's say the case manager that's been assigned to oversee all the patients with all the different facilities, they can go on and take a look and find out, what are the current orders and goals. And the transcriptions, we're just using that as an example. I mean, the transcriptions, you can see lab results from the patient. You can see physician notes. You can see, even if you wanted to be able to transcribe and put in your own clinical forms and notes, that information will now become viewable by everybody else. Now, the way that information is shared is two ways. And I kind of alluded to it before, but there's basically two methods. Number one, there's what's called a virtual health record. And what this means is that your HIE that's in your state is basically an online portal that you can go into, and you'll be able to view the patient's electronic health record via that online portal. And so it's a separate website that you go into and view that information. On the software side, if you have an EMR, for example, Healthcare Synergy, we've actually embedded that into our system so information is pushed and pulled. We don't have to go out to an auxiliary system on it. So you have two methodologies. You have the virtual health record that you can log in and look at, and then you have the interface with your common EMR software as well. Okay, so real world scenarios. Why would this whole, Mike, why are you talking about health information exchanges, about it? Because I see so much benefit that we can get even at this early adoption stage. Number one, notice of admission to ER urgent care. The example I just showed you. Hey, we know what it is. Next one. So we've got the proposed rule out there, right? And one of them is the new face-to-face requirements. And it now states that, use of hospital documentation for justification of homebound status. Unless you're a hospital-based agency, when is the hospital readily giving you any information? They're about as bad as the physician, right? So if the hospital is on an HIE, you'll have that type of documentation available that you can add to your patient's chart. Or when it comes time for a survey, where's the documentation to support the face-to-face for the homebound status? It's in the patient's electronic health record. Here's the notes from the hospital. Here's the notes from the doctor that show that coming prior to, coming on to home care. So even as we look at the 2015 requirements, the concept of HIE is going to be able to help us out. The big one, another one, is the care team concept. And I know a lot of people still kind of have that, ACO view, Mike, you're just crazy, pie in the sky. You keep typing hypothetical things. Well, we have to work together, no matter if it's in an ACO environment, traditional Medicare, Medicaid, private insurance, with multiple providers. And getting that concept of a care team that, truly when I look at the care team concept and you look at healthcare industry as a whole, and notice I said healthcare industry, the home care is the most viable option. Because I know even myself, when I get sick or when you get sick, where do you want to go? I want to go home to my own bed. If I'm going to be miserable, I don't want to be miserable at the office. I don't want to be miserable in a hotel. When I travel and I get sick, it's twice as bad when I get sick and I'm stuck in a hotel. I want to be in my own room. So that's why home care and hospice is such a viable solution for this care team concept. But we have to get into the idea of working with multiple providers and including that communication among the physicians. This is where some of that health information exchanges can come into. Now here comes another big one for us. Every agency I have talked to, when I ask them, what's your number one concern? Or what's your top 5 concerns? Number one has always been patient census. I don't have the number of patients I used to have. I'm trying to get more patients. And, joke around, but we see that the baby boomers are still retiring, right? They're still getting old. So that population is increasing, yet most of us, our census is stabilized or starting to decrease. Where are those patients going? Well, they're going to, sometimes they're going to our competitors. Sometimes they're going into these ACOs. It's wherever the physician's going. And I also know what it's like to work with a physician to try to get referrals, right? So remember how at the very beginning I spent a lot of time, boring time, talking about the 2009 HITECH Act, right? That these were the requirements that the physicians had to have in order to receive their incentive funds. And notice that I said the last obstacle was demonstrate meaningful use. And I said it's an obstacle for us, but it's also an advantage point for us. And part of the meaningful use that they have to do is to show that 10% of their patient population, they are exchanging data with another care team provider. So if your agency looks up and gets involved with a health information exchange, you can use that as a marketing tool to go to your physicians. Hey, listen, you get paid for the care plan oversight, right? Not a lot of money, but you get paid, $80, $100 for signing the document. I joke around, unless you're in certain parts of Texas and committing fraud, then you get paid a lot of money because you signed 140,000 485s, right? You guys remember that about a year and a half ago? But what can we do to help entice the physician? Obviously, we can't pay them or do anything else. Well, what we can do is show, hey, listen, my agency works with a health information exchange. And because I work with this health information exchange, now you can, prove legally that 10% that I'm one of those people that you're exchanging data with. I'm able to go in there and look at the continual care document, look at some of your information. And you can prove that statistically for the physician, so the physician can then use that when they have to demonstrate the meaningful use to get their financial incentive from the government. So it becomes more of a win-win scenario. And then a final one, which I don't have on there, is the fact that, hey, listen, on a access to an electronic health record of a patient. Let's look at a congestive heart failure patient. And again, I joke around. I'm not a clinician. I'm just married to one. But I've been around the block a few times. Let's look at a congestive heart failure patient. What we're thinking about always is weight gain, right? We see 3-4 pounds being added to this patient. Oh my God, they're starting to retain fluid. Something's going on. Well, when we develop our 485, we probably have the patient, if they gain weight more 3 pounds or 4 pounds, we're going to notify the physician immediately, blah, 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 blah. Well, without knowing what the vital history of the patient was, the weight history of the patient was the prior 60 days or 90 days, they may gain 4 pounds because they didn't eat in the hospital for a week. And we're getting all freaked out because, oh my God, the patient's got 4 pounds of gain, maybe, fluid retention. No, they're just regaining the weight that they lost from being sick for the last 3 weeks or 4 weeks. So the capability of using electronic health records in the 485 creation. And that becomes a very important part on how the quality of care that we take care of our patients. So that being said, I'm going to come pretty much up to my last question. Hopefully I gave you guys a lot of food for thought. Healthcare Synergy is not a health information exchange. We are a software and managed service provider. We have an EMR software. We've been in business for 20 years. We're not a health information exchange. I want to clarify that. I do have a list of all from 2013, because it's the most recent one I could find, of each state's individual health information exchanges. If you want to try to find yours for your particular state, I can send that to you. But what I wanted to show was that, this concept of that we need to all work together and exchange data electronically, regardless of what software system we're using. That's what's going to drive us ahead in the next 10 years. So that being said, that's pretty much all the presentation. If you have questions, obviously go ahead and type them in. I'm going to see if we have some here in a second. If not, I can always be reached at mike.deck@healthcaresynergy.com, or you can always call me at 714-229-8700, extension 321. All right, so let's see if we have any questions. Wow, can you believe that? No questions. Was I that confusing to everybody? Okay. Well, once again, I want to thank everybody for the opportunity, and, spending the last 50 minutes with me, an hour with me. I do want to thank PPS Plus. If you are new and not exactly sure what PPS Plus is, I'll put a little plug in for them. They're great guys down in the Gulf Coast of Mississippi, and they're really close to my heart because my family, we used to have a house in Mississippi before Katrina took it away. I was actually just down visiting the folks about 2 weeks ago. But they have some software to help analyze your systems, and obviously Healthcare Synergy, we're one of the vendors that we partner with them, so you can analyze the clinical documentation in our EMR using their tools and their services as well. So they're a great company to be partnered with, and an example of what I mean by vendors coming together and working together.